When studies have looked at the impact of insomnia on quality of life, they've shown that it has a huge impact on quality of life, on a par with congestive heart failure or major depression. And these are conditions that we would never dream of leaving untreated. So we should never dream of leaving insomnia untreated.
Hi everyone, welcome back to the podcast this week. My name is Anya and I'm a psychiatry registrar working in South London. I also have an interest in psychiatric research and I do some research related to depression. Today, I'm very excited to bring an episode to you on sleep. We welcome Dr. Hugh Selsick to the studio. Dr. Selsick is a consultant in sleep medicine and psychiatry at University College London Hospitals and is the lead clinician at the Royal London Hospital for Integrated Medicine and the University College London Hospital's Insomnia Clinic in Bloomsbury in the United Kingdom. So today's conversation mainly focuses us on insomnia, where we understand what insomnia is, what normal sleep is like. We think about whether our society's sleep is as bad as we think it is nowadays. We think about sleep treatments and what things like medication and CBT for insomnia involve. And we also think a little bit about dreams and nightmares and what's going on there. You have found the Thinking Mind podcast. This is a podcast where you can access conversations all about psychiatry, psychology, philosophy, and psychotherapy. I really hope that you enjoy this episode. And as ever, it's great to hear your feedback either by email or on social media. We love it if you can give us a rating if you value the podcast, as that really helps other people to find us, or if you leave us a comment about what it is that you enjoyed today. But otherwise, relax, tune in and enjoy. Dr. Selsick, thank you so much for joining us on the podcast today and welcome.
Thank you very much for having me.
It's a pleasure. So, Dr. Selsick, I'm hoping that we can talk all things sleep today, and this is going to be part of a special series that we are doing about sleep. So doing a deep dive into things related to probably adult sleep with you today, but we'll also be talking to people involved in children's sleep and hopefully doing lots of different topics on different bits of sleep. But I guess my opening question for you is, do we all sleep as badly as we think? What's your experience in your clinical practice in terms of the different problems that people come to you with sleep? What's the landscape like?
Well, look, I guess if you think about it logically, we spend a third of our lives sleeping, and so there is a lot of time for things to go wrong.
Okay.
Disorders are probably more common than most people imagine. At the same time, I think that there has also been a bit of a trend recently for people to monitor their sleep using various wearables and apps and so on. And this has perhaps put more focus on sleep than there needs to be for some people. The interesting thing about sleep is it's something that responds best to being allowed to do its own thing without having too much attention paid to it. And when people start paying lots of attention to their sleep because they have this app, on their smartwatch that allows them to do that, I think sometimes it makes people a little bit too focused on their sleep, and really what they should be judging their sleep by is how they feel they've slept and how they feel in the day.
What are the kind of sleep problems that can occur, or if things become more disordered, what can that look like?
So I think there's two ways to answer that question. And if you're coming at it from a professional perspective, we have broadly 6 categories of sleep disorder. So we have insomnia, where people aren't getting enough sleep. We have hypersomnias, where people are too sleepy. We have sleep-related breathing disorders like obstructive sleep apnea. We have circadian rhythm disorders, where the internal body clock is out of sync with the outside world, and that leads to sleeping at the wrong time. We have movement disorders like restless legs, and then we have parasomnias, which is unwanted experiences or behaviors during sleep or on the boundaries of sleep and wakefulness. And these could be things like nightmares, sleepwalking, sleep terrors, and so on. But I think if you come at it from the patient's perspective, really, patients will come with one of 3 complaints. Either I'm not getting enough sleep, I'm having too much sleep, or there are unpleasant things happening to me in my sleep. And so that's really what the patient will come to the doctor complaining of. And then our job is to tease out which of those 6 subcategories that patient's particular problem falls into. And of course, bearing in mind that it's entirely possible for people to have more than one disorder at the same time.
Gosh, so it's a really broad, quite a broad landscape in terms of the different things that can be going wrong. What are the common things that you tend to see in clinic?
Well, it will depend which clinic you're sitting in. And certainly in our clinic, the most common thing that we see is insomnia. But we see a lot of circadian rhythm disorders and restless legs as well. Nightmares are quite common. But for a lot of sleep disorder centers, their bread and butter is obstructive sleep apnea. I think insomnia is probably more common than obstructive sleep apnea, but most places don't treat it. And so the most common thing that sleep specialists are seeing on a day-to-day basis is obstructive sleep apnea. But all sorts of things will come through the door: narcolepsy, sleep sex, sleep eating, hallucinations. There are all sorts of really unusual things that can happen during the night. So it's one of the things that makes sleep medicine so interesting, is that it pulls in covers disorders that are really kind of respiratory, or that involve ENT, or that involve psychiatry, neurology. And so it's a really multidisciplinary area of medicine.
And I guess before we dive into some of the specific disorders, I'm wondering, you said sort of we spend a third of our life sleeping, so there's plenty of opportunity for things to go wrong. What is your sense of why we do spend so long sleeping? Why it can be something that people get so focused on with the sleep apps? Why is sleep important, but also why is it kind of attracting so much curiosity?
I think there are a few reasons. Part of it is that it's ubiquitous. Everybody does it. And so everyone has an interest in it. And it's a really mysterious thing. We don't fully understand all of the functions of sleep. If you think about it, sleep is actually a really vulnerable state. And yet the fact that all animals do it, and that all animals have a period of time where they have reduced reactivity to the outside world, where they're more vulnerable to predators, says to us that there must be something really important about it, that we put ourselves in this vulnerable state on a regular basis. But I think really the major issue is that we're all very aware that how we sleep has a big impact on how we feel, how we function during the day. And of course, we all want to feel well and to feel energetic, to have a good mood, to be productive. And we're aware that sleep is absolutely central to all of those things.
Yeah, for sure. I mean, just using my own experience, I know that I can tell that I've not quite had enough sleep because I'm particularly grumpy and particularly irritable and short in, sort of my bandwidth for what I can tolerate in terms of minor irritations of life goes way down. Do we know why that is?
Well, there are a number of potential reasons. Certainly one of them we know is that when you haven't had sufficient sleep, whether this is because of insomnia or whether it's because of sleep deprivation, where you just haven't had enough opportunity to sleep, or there's something disrupting your sleep, that your brain does tend to preferentially focus on negative aspects of situations and is more likely to recall negative memories than positive memories. So something about this lack of sleep biases towards more negative cognitions. Some of it really is just that, during the day, there are all sorts of things that will irritate us, the things that might make us want to snap, but we're able to kind of damp those down. Our higher kind of consciousness, our higher brain function will go, okay, that's not an appropriate impulse. We're not going to shout at that person. But it's that part of your brain that's the most easily affected by lack of sleep. This prefrontal kind of controls impulses and decides which impulses it will allow to run out and which ones it will try and suppress, is the part of the brain that is most knocked out when you are tired. And therefore there's much less there to inhibit these impulses. And so when someone does something that makes you want to snap, you just snap. You don't have that higher control to the same extent.
And I guess we can really see there where that starts to take us towards the interaction between sleep and psychiatric disorders, where I assume your sort of specialism as a psychiatrist must be really useful in your clinical work as well.
Yeah, very much so. I think, we know that sleep problems are almost ubiquitous amongst patients with psychiatric problems, particularly insomnia, but all of the sleep disorders have a relationship with psychiatric disorders. And, at the same time, working in a sleep clinic, you see a lot of patients with a whole range of psychiatric conditions coming through the door because there is such a strong interaction between sleep and psychiatric disorders. I've often commented, I think I've seen more psychiatry in my sleep clinic than I ever did in a psychiatry outpatient clinic.
Gosh, okay. What kind of things? How? I guess people are coming to you with the sleep problem first, but then they have sort of issues going alongside that you pick up?
Yeah. So, really, really common is people coming with insomnia and depression, or sleep apnea and depression. These also come along with lots of anxiety disorders. Patients with sleep problems are often not able to access the help they need, which then leads them to self-medicate, and therefore you see quite a lot of substance misuse. But really, any psychiatric disorder, as I said, there's an interrelationship with sleep. So we will see people coming in with schizophrenia, bipolar disorder, a lot of ADHD, patients with various autistic spectrum conditions. We're integrated beings, and therefore sleep is going to interact with pretty much everything, both physically and mentally.
So I guess if we dive into insomnia a little bit, what can that be like? How does it arise? Why do people struggle to sleep if it's such an important part of our well-being and something that all animals sort of do naturally? Why does it go wrong?
So I think in order to answer that, it's worth firstly just defining what we mean by insomnia, because we use various terms like insomnia and sleep deprivation and lack of sleep and short sleep very interchangeably, and they're not necessarily the same thing. So insomnia is difficulty getting to sleep or staying asleep, which might include waking up too early in the morning. And this then leads to daytime consequences: tiredness, irritability, concentration, memory problems, mood problems, and so on. And it's probably the most common of the major sleep disorders. And he suggests that anything from about 5 to 10% of the adult population suffer from chronic insomnia. So it's a really common condition. And trying to kind of pin it down to one single cause is impossible. It's an incredibly multifactorial thing. So, but the way that we really approach it, I think that's a useful model, is what we call the 3P model developed by Spielman, which is that there are predisposing, precipitating, and perpetuating factors in insomnia. So the predisposing factors, to a large extent, are genetic. Certain things will make you a little bit more likely to get insomnia, like being female, being postmenopausal, things like that. But even if you've got a very high predisposition to getting insomnia, that doesn't mean that you will get it. Now, that predisposition might lie dormant your whole life. But at some point, for people with insomnia, there has been a precipitating event. And this could be any one of thousands of things. So, going through a messy divorce, work problems, noisy neighbors, depression, menopause, knee pain, you name it. The list is absolutely endless. But something has tipped that person from being a good sleeper into having insomnia. And when they get this insomnia, they're going to respond to it in various ways. They'll respond psychologically, behaviorally, and sometimes even physiologically. And if they're very lucky and the way that they respond happens to be the right way, then when that precipitating event resolves, they go back to sleeping well. But unfortunately, very often what happens is that the way that people respond, rather than making the insomnia better, makes it worse. And I'll just give a couple of examples. So when someone develops insomnia, they start to worry about their sleep. They get very anxious about their sleep. They're obsessing about it, which is understandable. But of course, if there is one thing that sleep does not respond well to, it's anxiety. And that then makes the insomnia worse. A behavioral response is that people who are not sleeping well say, well, look, I'm not getting enough sleep. I must give myself more opportunity to sleep by spending longer in bed. That's a perfectly logical thing to do, but actually that makes the insomnia worse. Because all that happens is they spend longer in bed awake, which then reinforces to them that their sleep is broken. And a physiological response that we think happens for some people is that because they are so tired day after day after day, that their brain increases its level of alertness to try and offset that tiredness just to get them through the day. And it does help them to drag themselves through the day, but it means they're going to bed every night now with this much more active brain, which again makes the insomnia worse. And then generally speaking, by the time insomnia patients come to see a medical professional, they'll say, well, look, I know why I got insomnia 10 years ago because, I was going through a really difficult time in my relationship or whatever, but now everything's resolved. My life's good. I've got a great job. I've got a great spouse. Why can't I sleep? And it's those responses, those psychological, behavioral, and physiological responses that have now become the perpetuating factors that have given the insomnia a life of its own. And therefore, treating the insomnia, it's those perpetuating factors that we need to tackle.
Gosh, okay. So, because the question that pops up in my mind is a lot of the patients, for example, that I will see in psychiatric practice will tell me, how long have you been struggling to sleep? Forever, as long as I can remember, or my whole life. And that kind of speaks to what you say, the people who come to see you and say, 10 years on, I'm still struggling to sleep. There's no obvious cause for why I'm struggling to sleep. How do you manage the perpetuating factors once you've identified them when it's so chronic?
As with many things in mental health, and I really do think, we should be considering insomnia to be a mental health condition, a psychiatric condition. The first line treatment is cognitive behavior therapy for insomnia. Because if there are psychological and behavioral factors that are perpetuating the insomnia, we can use psychological and behavioral techniques to treat that, to show people the right way to respond so that they go back to sleeping well. And actually, the amazing thing about CBT for insomnia, or CBTI for short, is that it doesn't only work on a psychological and behavioral level, but it works on a very physiological level as well. It shows people how to optimize their innate sleep drives. How to utilize their sleep drives to improve their sleep. And these are physiological drivers. So it works on all three of those levels. And that's, for chronic insomnia, that should always be the first line wherever possible. And one of the problems really is that there's such limited availability of CBT for insomnia internationally and across Britain. So the other alternative is medication, and there are some medications that can be very effective, that can be very safe if used in the right way. But the thing to say about medications is that medications treat insomnia, they don't cure it. And therefore, if you stop the medication, you've now got untreated insomnia again, and of course, you're going to go back to sleeping badly. And this is very often mistaken for addiction to the sleeping pill, which it's not. It's just that if you have a long-term condition, you may need to be on a long-term treatment in the same way that if you have high blood pressure and you stop your blood pressure medicine, your blood pressure is going to go back up and you're going to go back on the blood pressure medicine. But what it does mean is that if your only strategy is to use medication, then you do have to accept that this might be, a lifelong treatment.
What do you think about medications in insomnia? Because I guess, I think for myself and speaking to colleagues, at my stage of training, there's often quite a reluctance and sort of a worry about using them, sort of a concern about this idea that people might need them for a very, very long time.
When studies have looked at the impact of insomnia on quality of life, they've shown that it has a huge impact on quality of life, on a par with congestive heart failure or major depression. And these are conditions that we would never dream of leaving untreated. And so we should never dream of leaving insomnia untreated. And I think that this is something that's really important to point out because, yes, every medication has risks, not just sleeping medications. Every medication comes with risks. And there are some risks and downsides to sleeping medication. And it's very easy to say, well, those risks are not worth it if you think that insomnia is not a major problem. But when you realize what a huge impact insomnia has on people, how it can really ruin people's lives. That balances the equation out a little bit more and makes you realize that actually there are times when it is appropriate to prescribe medication, even potentially to prescribe medication long term, if that makes the patient's quality of life better. So I'm neither for medication nor against medication. I'm just very much for sleeping well. And if we can get people sleeping with CBT for insomnia, which can cure the insomnia, not just treat it, that's the gold medal position. But if we can't do that, then, medication, sleeping well with medication is the silver medal position, and silver medal is still pretty good.
What does CBT for insomnia involve?
So it can be delivered in a whole range of ways. There are books on it. There are automated programs on the web and apps. It can be done in groups, individually, face-to-face or online. But generally, the most commonly used model is having around 5 or 6 sessions. In our clinic, we tend to do it primarily in groups. And the first part of it is psychoeducation, is helping people to understand how their insomnia is developed, understand that 3P model we talked about. And that way they understand how the therapy is going to help them. Also, it's about explaining what normal sleep looks like, because if you've been sleeping badly for ages, it's really easy to idealize good sleep, to look at good sleepers and go, oh, well, they never have a bad night and they never feel tired in the day and they never wake up in the night. And actually what that then does is it makes them feel, well, I am a million miles away from good sleep. But when you come to realize that good sleep is not perfect, that, good sleepers do have bad nights, that good sleepers wake up a few times every night, that everyone has the odd bad day or the odd bad run of days, then that brings good sleep a little bit closer to where you are and makes it feel like a more bridgeable gap. We then tend to focus next on the behavioral techniques, because the evidence is that it seems to be these techniques which really kickstart the process of sleeping better. So we, as I said, kind of harness these innate physiological sleep drives, which will involve techniques like setting an alarm to wake up and get up at the same time every day, because this helps to anchor your circadian rhythm. And it also means that you start accumulating sleepiness at the same time every day. And so the point at which you have enough sleepiness to fall asleep at night, it will become more consistent as a result. Asking patients to avoid napping and actually getting them to go to bed later, which is sometimes a hard sell when someone's very tired, to say, you should spend less time in bed. But we show them how to work out exactly the right amount of time to spend in bed. And this usually involves going to bed later and spending less time in bed. And what this does is this then really optimizes these physiological sleep drives, what we call the circadian rhythm and the homeostatic sleep drive. The homeostatic sleep drive being a fancy term for sleepiness, really. It is a physiological sleep drive. And improves the quality of their sleep, and in the longer term will improve the quantity as well. We'll use some behavioral techniques that harness classical conditioning or Pavlovian conditioning, where when you've got insomnia, you come to associate your bed with struggle rather than with sleep. And when you walk into the office, your brain switches into work mode because this is where you've always worked. If you walk into the gym, your brain and your body start switching into exercise mode because this is where you exercise. So what we want is when you go into the bedroom for your brain and body to switch into sleep mode. And so we use techniques to really create this conditioned response so that this is what happens. And to a large extent, what this really involves is essentially spending no time in your bed or your bedroom unless you're asleep. And then we give a relaxation technique, and we move on to the cognitive techniques. And the evidence is that it's these techniques which give the improvement longevity, that they kind of perpetuate the improvement. And I think this is really kind of focused on things like quietening the mind down at night, dealing with anxieties about sleep, and dealing with anxieties about life in general that might be interfering with your sleep, and refocusing the attention on the day, on how you make yourself have a good day, so that there's less attention focused on the sleep. And then wrap this all up into a nice package. And what it means is that we're attacking the insomnia from multiple different angles, because insomnia is multifactorial. Patients will often say, oh, I've tried that technique and I've tried that technique, but usually they've tried them in sequence. And because there might be 3 or 4 or 5 things driving their insomnia, it works much better when you do all of these things together and tackle them all at once.
When you say you might do some cognitive work, what are the kinds of, I guess, beliefs or thoughts that you might work on with people? What might you do?
So some of it is, doing kind of fairly straightforward CBT anxiety management, getting them to think about, if I have a catastrophic thought, rating, well, how stressed am I by that thought? And then writing down, well, what's the evidence for this idea? What's the evidence against? Let me look at the two and weigh up again, well, how stressed am I about it now? And, this is something that can be used to tackle some of the anxieties about sleep and, the anxiety about, finances or work or family or whatever else that might be interfering with your sleep. We give some distraction techniques to quieten the mind down at night. So ways of just kind of reducing the washing machine thoughts that are not particularly stressful, but that just don't want to get out your head. And also really to, as I say, we want to try and really shift the focus away from sleep to some extent. So we do quite a lot of work around really getting people to focus on what are the other things besides sleep that impacts on my day. That will determine whether I have a good or a bad day. And, really focus them on, well, what are the things that I have control over? Because no one ever has 100% control over their sleep, even if they're a great sleeper. And that can be a frightening thing when you've got insomnia, this idea that you don't have you don't have much control over your sleep or as much as you would like. So it can be really helpful then to really shift the focus onto, well, I can control whether I exercise or what I eat or whether I, spend time with my pets. And that really kind of allows them to kind of shift the focus away from sleep, which sleep responds to well. If sleep was a person, it would have stage fright. It doesn't like being the center of attention and being given loads of responsibility. And if you say to your sleep, whether I go to the movies tomorrow is entirely dependent on how you perform tonight, you've just heaped all of that pressure on your sleep. So what we really want to do is say, well, look, I'm going to go to the movies and I might be a bit more tired if I haven't slept, but I know that if I walk to the cinema instead of catching the bus, I'll feel much more awake. And so these are, it's really focusing on those things that you can control. And then actually you've taken a lot of the pressure off sleep, which means that sleep is much more able to perform.
Gosh, that must be such a change of mind for people to have if they've got, like again, the people who say they have 10 years or a lifetime of poor sleep. How do people kind of respond to that idea?
I think at the beginning, a lot of people are understandably skeptical. Okay. I could probably count on the fingers of one hand the number of patients who, when they come to the clinic and they say, what have you tried? They, have not said to me, oh, I've tried everything. So when you say, well, I'd like you to try this thing, they go, really? I mean, I've tried that, or I've tried something similar, or, I've tried so many things I can't believe, even if this is different, that this is going to work. But when the amazing thing about these techniques is you don't need to believe in them for them to work. You just need to do them. And so when patients come back and they say, well, I really didn't think this was going to work, but oh my gosh, it's amazing. And, and they'll say things like, I'm so angry. If I'd known this 20 years ago, the last 2 decades of my life would have been different. So it's incredibly rewarding work because you really do see people's lives change for the better.
I mean, it's pretty remarkable. You say in your clinics you do 5 to 6 group sessions. Is the length of treatment, which I mean that sounds very achievable in most clinical settings, and yet, I mean, I've really, I work in London. I have yet to be able to find somewhere where I can refer people to in-person CBT for insomnia. I mean, I sort of have, there's apps periodically that are free that I kind of manage to get people onto, but there's such why is there such a shortage of this, or what are the barriers, do you think, to this being available?
So if I'm being cynical, I think part of the issue is that it's something that up till now has just not been treated. And it's very difficult to find money to treat something that is so incredibly common, that's going to pull in so many patients. and with such a big demand on services, if you haven't had to pay for it already, it's easier just to, to some extent ignore it. I think part of it is that there hasn't been this recognition of what a serious condition insomnia is. And I think that is gradually changing. I think people are really, if you'll excuse the term, waking up to the fact that insomnia is a really serious psychiatric condition. It has this huge impact on quality of life. But I think, historically that's not been the case. And I think there's also been a slight sort of odd issue in the UK when it comes to sleep medicine, which was that sleep medicine used to be the domain of psychiatrists, because sleep is a state of mind, so it stands to reason that psychiatrists should be involved. And I think what happened was that when CPAP was developed for obstructive sleep apnea, suddenly we had this really clear physical treatment that you could measure and monitor. And you could say this person stopped breathing 70 times an hour before we started them on the machine. They're now stopping breathing 3 times an hour. That's a clear improvement. It's very easy to measure. And what it did to some extent is it lifted sleep medicine out of psychiatry's realm and placed it in the realm of respiratory physicians. And although there are some respiratory physicians who are really good at kind of working across the whole range of sleep disorders, because insomnia itself is such a psychiatric condition, and it does require an understanding of CBT, of psychological mechanisms and of psychopharmacology. I think, a lot of these respiratory physicians who are running sleep clinics were not particularly confident in dealing with it. And so it's something that has never really been at the forefront of sleep medicine, despite being the most common disorder. And given that sleep medicine is never really been at the forefront of medicine in general, insomnia has been very far down the list of policymakers' priorities.
Interesting. Okay. And I mean, I guess thinking about now and what can be done, is there a difference between delivering CBT for insomnia in a group versus to something that people would do by themselves using an app? Do we know if one is better than the other?
So, look, the apps can be a good first step, and we know that they're not as good as face to face or having a real live therapist. And the reality is that the protocols for CBT for insomnia are often very clear cut. They're very clearly defined by the research. The protocols are very set and clear, but patients are not set and clear. Patients are fuzzy, bumpy, people with all sorts of additional problems and challenges and work patterns. And unfortunately, the automated programs can't really account for all of those. And so I think they are a really good first step, particularly, given how little CBT for insomnia is available around the country. But what I would always say to a patient is, if you do it online and it hasn't worked, don't give up on the system. Come and do it with a real therapist who might be able to work out why this hasn't worked. What, you might just be getting one tiny thing wrong. And if we correct that, it sends you on a completely different trajectory.
And when it comes to sleep medications, are there sort of new, or sleep treatments, I guess, are there new things on the horizon for insomnia that you're interested in? But also kind of a second part to that question is, do we need new things, or do we actually have quite good treatments already? We just don't, as you were saying, medications aren't necessarily bad. They just need to be used in the right way. So are we there? Do we just need to do it better?
I think we do need more medication, because again, insomnia is very multifactorial and it affects patients in different ways. And for example, the medication that you need for a patient who just has difficulty getting to sleep is going to be different from the medication you need for a patient who has difficulty staying asleep or wakes up too early in the morning. The kind of patient that you might give a medication to, quite comfortably, if they then suddenly start driving, and you think, okay, hang on, they're going to be driving in the morning, only a few hours after taking a sleeping medication, I need to switch them to something completely different. And when you look at our formulary for sleep, it's actually relatively restricted, and you compare that to, other disorders where you'll often have dozens of different medications. We have a very limited range of medications that we can choose from. And it's very frustrating. And we look across the pond at the States, for example, where they have a much wider range. And I really think I would love to have some of these medicines, because I have patients who would really benefit from that particular medication, from that particular medication's way of working. And so I think that there really is a need for more medications. We have two newish medications in the UK, and it's really been the first time in a long time that we've had any new insomnia treatments, to be honest. So we have this new one, daridorexant, which is now quite widely available, and also a medication called S-zopiclone, which is, I say it's newish because it's been available in the States for many, many years, but it's new here in the UK. And so that at least has slightly increased our options now from where they were before. For most of the last, I've been in the UK for 25 years, and most of that time, we have had exactly the same medications. In fact, the number of medications we've had to treat insomnia has at some point dropped when a medication called Zaleplon was taken off the market. So, so we really do have a need for more medication options.
I mean, I guess I'm particularly interested in, given your expertise, in your thoughts about the different medications. So we have sort of the Z drugs, so things like zopiclone, and then different lengths of duration of action of some other Z drugs, and they're, I guess, sort of kind of sedative medications. We have things like melatonin, which people seem to use quite freely, and we have this perception that it's fairly harmless. And then we have sort of things that might be used to treat depression, which are sedative, and therefore we give them at night, and they sort of help people sleep. That's my, I guess, very basic understanding. What's the reality on the ground when you're working? What do you tend to use? When do you tend to use it? What do you think about this melatonin freedom, I guess?
So very often, really, the prime thing that I'm thinking about when a patient needs a medication is when in the night do they have the problem. Because if it is the beginning of the night, then I want to give a short-acting drug, because that will get them to sleep, but it'll then come out the system, and they're much less likely then to have any hangover the next day. If they have more difficulty staying asleep, then I will want to use a longer-acting drug, something like zopiclone, or completely outside of the license, a sedating antidepressant, because these can be very, very good at consolidating and extending sleep. But we'll also have to take into account things like, if someone is, for example, a single mother with a young child at home, we wouldn't want to give something that is so sedative that if their child was ill in the night, they wouldn't be able to respond to them. So we'd have to select the medication that's going to allow them to improve their sleep without having significant sedation all the way through the night. As I said, if they drive in the morning, we don't want to use longer acting drugs because of the risk of being drowsy behind the wheel. And sometimes it's also about trying to avoid polypharmacy, trying to avoid having too many medicines. So if someone has depression and insomnia, it makes sense to use a sedating antidepressant as a first line, because you could potentially treat both conditions with a single medication and therefore reduce the burden of side effects. So these are all things that we need to take into account when we're deciding which medication to use. There's also, if I'm honest, a certain degree of pragmatism, which is that sometimes we think a patient might do very well with a Z drug like zopiclone. But we also know that very often if we start a patient on a Z drug, we're setting them up for a lifetime of stress every month as to whether that prescription is going to be renewed. Because there is this prejudice against sleeping medication. There's this somewhat irrational fear of sleeping medication, and therefore very often when patients go back, for example, to their GP to get a repeat prescription, they get sort of put through the ringer about why are they on this absolutely terrible drug, and this is going to be the last month, but you can't have any more. And we don't want to set people up for that amount of stress. In fact, if anything, that makes them more focused on the medication, because it becomes the most precious thing in their lives. And so we might say, okay, look, I'm just going to put you on a sedating antidepressant where I know, when you go each month to get your repeat, they're just going to give you the repeats, and review you once a year to see if you still need it. So there is that degree of pragmatism that we have to sometimes think about as well.
And what do you think about the use of melatonin?
So melatonin is a very short-acting medication, and so it can be helpful for sleep onset insomnia. But it's really not helpful if people have any difficulty with staying asleep or waking up too early in the morning. We do also use it a lot in sleep medicine for the circadian rhythm disorders, the body clock disorders, and in particular this thing called delayed sleep-wake phase disorder, where people fall asleep very late and then wake up very late. We use melatonin as a time signal rather than as a sleeping pill to pull their body clock forward so that they fall asleep a bit earlier and wake up a bit earlier. And we also use it for this condition called REM sleep behavior disorder, which is where people act out their dreams. Normally, when we're dreaming, we should be completely paralyzed, and that stops us acting out our dreams. But with REM sleep behavior disorder, the person's not paralyzed, and they will then act out the dreams, which can lead to them injuring themselves when they throw themselves out of bed or accidentally punching a bed partner and so on. And we use melatonin for that. So overall, look, the safety profile of melatonin is very, very good. Again, there is nothing that is 100% safe. And what we certainly wouldn't condone is just kind of taking melatonin for the sake of taking it, or saying, well, I'm just going to, taking it without some kind of medical input and supervision, because as there are sometimes potentially problems. But overall, the real world data from melatonin, given that it's been available in health food shops and supermarkets in many countries for many years, are usually at much higher doses than we would use in the UK. And the fact that there haven't been very many serious adverse outcomes to this, suggests to us that it probably is a reasonably safe medication. But it is a medication, and it should be, should be prescribed by someone who understands it, knows what they're doing, and is able to monitor it.
And this new medication, daridorexant, and this might, this and talking about melatonin may bring us to talking about what normal sleep is like, sort of what the homeostasis of sleep is like, which you've mentioned before. But what is new about daridorexant? What's it about?
So, if we look at the sleeping medications that we have at the moment, we have melatonin, which obviously acts on melatonin receptors. Antihistamines and most sedating antidepressants act by blocking histamine, so they act as antihistamines, although they do have some other actions as well. And then your benzodiazepines and your Z drugs, things like temazepam and zolpidem, act through this neurotransmitter GABA. And particularly GABA is very widely spread throughout the brain. There are GABA receptors, all the way through the brain. And so if you enhance GABA's function, and GABA is a sedating neurotransmitter, it does kind of sedate the brain as a whole, if you like. What's different about the daridorexant is that it acts on a different neurotransmitter called orexin. And it blocks the orexin receptors, and orexin is a wakefulness promoting neurotransmitter. And it's orexin, the orexin pathways in the brain are quite specific, so it's a much more targeted kind of treatment. At the end of the day, whether it is better, worse than other medications, it is a completely different option. And it's as I say, it's the first time in a long time we've had a completely different option. So there are some patients who just don't respond to the drugs that act on GABA or the drugs that act on histamine, or have side effects from those. And so for the first time, we've now got a different class that we can go to and say, well, okay, let's try something that acts in a completely different way.
Okay. And could you tell us a little bit more about how these different neurotransmitters work? How does sleep get created, if that's the right word, in the brain?
That's a very difficult thing to answer, because actually it's complex. We have a number of different interacting centers in the brain that control sleep. And when in some sense, when you think about on a purely practical perspective, you can look at the brain as being like a circuit board with all of these different interacting circuits. But that's not really that useful, because we can't go in and adjust little, this aspect of the circuit or that aspect of the circuit. I really think of our brain as being a little bit more like a test tube or a beaker in a chemistry lab, where we pour a chemical in and it mixes in and does its thing. And so I think the way to really think about what drives sleep and wakefulness is just to think about the chemicals that are involved in sleep and wakefulness. And so chemicals that promote sleep are this chemical GABA, melatonin, and adenosine. Adenosine is a breakdown product of energy utilization in the brain, but it's also a sedating neurotransmitter. And it's this adenosine that we think is actually the physical substrate of sleepiness, of that what we call the homeostatic sleep drive, and that you're building adenosine up during the day as your brain uses energy. And this is what makes you more sleepy. And then when you start, you remove the adenosine, and that then makes you less sleepy, so you wake up in the morning. On the flip side, there's a wider range of chemicals that promote wakefulness. So we have histamine is a really big driver, serotonin, noradrenaline, dopamine, acetylcholine, and this relatively newly discovered neurotransmitter, orexin. And I think, what's striking, if you look at that list, if as a psychiatrist, when you write a prescription, you are going to be manipulating one of those chemicals. That is the list of chemicals that we work with as psychiatrists, and therefore, every time we write a prescription for a psychiatric medication, we have the potential to do something to a patient's sleep, for better or worse. And so, for the professionals listening to this, what I would always say is, always have that question in your mind when you're writing a prescription: how might this affect my patient's sleep? What does that tell me about whether the patient should take that medication in the morning or in the evening, and so on?
And sort of understanding that sleep drive, that kind of buildup of adenosine throughout the day, that also then leads to understanding what things like naps in the middle of the day might do to disrupt it. And is it also sort of why, maybe being more active or doing exercise might help us to sleep better because we're sort of using more energy and creating more adenosine, or is it not quite that straightforward?
If only it was that straightforward. So you don't have any kind of really good ways of, at least in the short term, accelerating your adenosine accumulation. That would be a great way of treating insomnia. We do have some really good ways of letting some of that adenosine, some of that, what I sort of think of it as your sleep fuel, letting some of that sleep fuel leak out. And the way that you do that is by sleeping. So any sleep that you have in the day is going to reduce the amount of adenosine available to sleep that night, and it's going to have a negative effect on sleep the next night. Now, I think I should just qualify this by saying, if you are sleep deprived, if you are sleepy because you didn't get enough sleep last night because your neighbors kept you awake, or you have a small baby who's feeding 3 times a night, or you were working a night shift, then absolutely the right thing to do is to sleep, to take a nap, to get rid of some of that adenosine to make you more alert. But if you have insomnia, the advice is the exact opposite. You want to hold on to that adenosine as much as you can. You want to hold on to that sleep fuel and not allow any to leak out during the day, so that when you go to bed at night, you've got a really full tank full of the sleep fuel, able to kind of get you to sleep more easily and give you a much more solid sleep through the night.
What do you make of sort of the cultural phenomena where people have naps, sort of culture, certain parts of the world where it's very promoted to have a nap in the middle of the day? So what's that about, do you think?
Human sleep is very adaptable, and we can adapt our sleep to a whole bunch of different circumstances. And when you look at, for example, Southern European Mediterranean societies where there is a siesta during the day, what you'll also notice is they tend to have a much shorter sleep at night. And so they're getting essentially the same amount of sleep across the 24 hours, but just broken down into two separate episodes. So, if that is the sleep pattern that you're living with, if that's a society you're living in, then that's absolutely fine. You have a siesta in the afternoon and a shorter sleep at night. The problem is in Northern Europe, where we don't have a siesta, where we still want to have our 7, 8, 9 hours sleep at night, having a nap during the day is going to make it really hard to get that 7, 8, 9 hours sleep at night. And of course, we also, very often just don't have the facilities at work or in the kind of the setup of our working day to be able to take a nap on a regular basis. And therefore, it's not something that we can practically do very easily.
You mentioned sort of the setup of society, the setup of our working lives in Northern Europe, I guess, specifically. What do you think is the relationship between that and the high rates of insomnia that you mentioned? There's 5 to 10% of adults. Is there something about modern society in Europe that is contributing to those high rates? Are those rates higher than they used to be? Or has it been fairly steady across the years?
It's very difficult to say. Certainly we're seeing a lot more insomnia, but this could just be because people are reporting it more, because people are actually saying, well, hang on a second, this is something that can be treated. I'm going to go to my doctor and ask about it. If you think about the way people slept until relatively recently, for example, people, it was much more common until probably in some places, even into the 20th century, for whole families to sleep in the same room, or even for more than one family to sleep in the same room. And that would have an impact on people's sleep and on people's sleep patterns. Although it doesn't always feel that way, we probably are safer in our beds now than we've ever been. And so, that might potentially actually be reducing the incidence of insomnia. But I do think there are a couple of things that might be having an impact at the moment. And the first is really the fact that there is no longer, for most people, a hard end to the workday. Example was used as if you worked in a lumber yard and the lumber yard closed at 5, there is nothing you could do for work until 9 o'clock the next morning. So you would just switch off from work. But actually, for most of us now, we are checking our emails, we're checking our social media feeds. We're thinking, about whether we can update the spreadsheet for work. So I think in a way, work is really kind of encroaching on our personal time, and that does have an impact on our sleep. Another thing that has happened much more recently since the pandemic is that there's been this increase in working from home. And I think this means that people are slightly less physically active sometimes because they just don't have that walk to the tube station or the bus stop to get to work, or the walk around the corner to get a sandwich at lunch. They may be getting exposed to less sunlight because they don't need to leave the house. And perhaps most damagingly, there's been an increase in people working in their bedrooms. And as we said, if the bedroom is a place where you work, then when you walk into the bedroom, your brain is going to switch into work mode instead of into sleep mode. And so, I think that this is an issue, and we are certainly seeing it in some of our patients that this is a big problem, and one and can be a difficult adjustment for them to be able to find ways of taking their work outside of the home. When, for example, their company may no longer have the offices for them to work in.
Certainly issues from the working from home crew. Do you have a sense of problems related to sort of technological devices, phones, laptops, TVs? Again, I think there's a lot of talk about this, but is it as bad as we think it is to have these devices around us?
You've led me into a real minefield here, and I'm going to say something a lot of professionals will probably disagree with. But I think we are a little over-concerned with screens. And certainly in our clinic, we do not tell our patients that they're not allowed to use screens at night. Look, there are I think, four aspects of screens to think about. The first is the content. What are you watching or using? If you're lying in bed or close to your bedtime, you're doing work stuff or watching a horror movie or something, that's clearly not going to be great for your sleep. A second thing is that bright light can be alerting. And so sitting very close to a bright screen could potentially make you feel a bit more awake. And again, that can potentially be a problem, but it's also a very manageable one. All devices allow you to dim their screens nowadays. And actually, the amount of light that you get from a screen drops off with the square of the distance. So if you double the distance between you and your screen, the amount of light you get drops to a quarter. Double it again, and it drops to a 16th. So simply just having a decent distance between you and the screen really minimizes the amount of light you get. And for this reason, we actually don't think that TVs have very much impact because TVs are big, but you sit quite far away from them. Another factor is that screens are often very bright in the blue part of the spectrum. Think about down a residential street on a winter's night and you see all the living room windows flashing blue from the TV. And our eyes are particularly sensitive to blue lights. And the blue light is particularly effective at impacting on our body clock. And so the concern was, if you're looking at bright blue screens at night, will this not delay your body clock and make you fall asleep later? And I think that this is certainly potentially an issue with children. It's much less of an issue with adults. And actually, the studies show that the impacts of blue light on adults at night is relatively minimal. So one study that got a lot of press, for example, was talking about reading on an e-reader at night. And they said, well, this delayed sleep onset, which it did, but it delayed by 8 minutes, which was statistically significant, but not really practically significant. And then the final issue is where you use screens. And again, what we would say to people is, if you are having trouble with your sleep, don't use the screen in the bedroom because that's a waking activity, and waking activity should be done in the waking space, which is outside the bedroom. So if you're sensible about how you use screens, it's absolutely fine. And I think it's also, the reality is we live in a society where this is our way of interacting with the world, as you and I are doing right now. And so to say to people, oh, you are never allowed to use a screen at night, you're setting them up to fail. People are not going to be able to do that. And then very often there's that sense, well, if I'm breaking that rule, I've blown it all. There's no point doing anything else. So rather than set them up to fail, we'd rather focus on changing things that have a much bigger, more significant impact on their sleep.
Yeah, no, that's really, really interesting. And as you say, actually quite refreshing, I guess, pragmatic thought of what is realistic for someone to be able to do, and actually how bad can it be? Because, yeah, as you say, 7 to 8 minutes, even if statistically significant, clinically and personally probably doesn't make that huge a difference. I guess the last bit that I'd like to think about together, and we touched on this, but is around this interplay between psychiatric disorders and sleep disorders. And I guess if you have a sense for why they're so intertwined, and what's that relationship like when you see it, and including things that are very common that might be seen in general practice, sort of depression, anxiety, but also the more severe and serious mental illness that will be a psychiatrist's bread and butter.
So I think the first thing to say is that it's the relationship between sleep and psychiatric disorders is bidirectional. Sleep disorders predispose you to psychiatric disorders, and psychiatric disorders will predispose you to sleep disorders. And I think one of the mistakes that we always made, particularly around insomnia, was to sort of think of insomnia as being secondary to something else, to think of it as being a symptom of another condition. And if you look, for example, at the definition, the diagnostic criteria for depression, insomnia is one of the symptoms, as one of the diagnostic criteria. And so it's natural to think, well, insomnia is a symptom of depression. And also, if I treat the depression, then the symptoms get better, so the insomnia will get better. And actually, the research shows that this is not really the case. That first of all, very often insomnia is the primary condition, which then leads to the depression. Insomnia is a definite, modifiable, significant risk factor for depression. And insomnia can precede depression by many, many years. So one study looked at medical students from Johns Hopkins, I think, followed them up for about 40 years. And what they showed is that those who had insomnia at the beginning of the study, none of these people had any history of depression, but those who had insomnia at the beginning of the study had a much higher rate of depression through their lives, and that insomnia at time zero actually predicted depression as much as 3 decades later. So it's not just that it's the first kind of prodromal symptom of depression. So it's it's a modifiable risk factor. But of course, once you get depression, with the negative cognitions, with the anxiety that often comes with depression, that's going to feed back into the insomnia. And so really the message that we have is, when you've got a psychiatric condition and a sleep disorder, treat them both. Don't assume that you treat one, the other one will automatically get better. So we see these interactions with all sorts of other conditions. So restless legs are very common in patients, for example, with ADHD. But they're also a side effect of many of the psychiatric medications we use. So that throws in a third spanner in the works, which, a third factor is that the medications we use might cause restless legs, or they might cause insomnia, or they might improve restless legs or insomnia if you're choosing the right medications. So there's a whole complex interaction. And I think, as I say, we don't fully understand what all of the functions of sleep are, but we know that it is important for cognition, for mental functions, for memory, for impulse control, for attention, for concentration, and that it has an impact on your mood. And so if your sleep is not optimized, these various aspects are going to suffer. And these are all of the things that feed into the psychiatric conditions. There's been some thought over the years as to whether there is a relationship between psychosis and dreaming, and whether there might, in fact, be kind of common underlying chemical and neurological pathways that mediate both. And there is some evidence that the same mechanisms are involved, but quite how they interact is still uncertain. So I think we're really only at the very beginning of understanding this relationship between sleep and mental health. We know it's there. We know it's important. We know that when you've got both, you treat both. But there's still a lot more that we need to discover.
I'm very curious about that idea of the relationship. Well, there being some relationship between dreaming and psychosis. What's the work that's been done on that? What got people curious with that?
I think some of it is just if you think about what it's like to dream, it is about as close to a psychotic episode as most people will experience. You are having a really vivid hallucination. There is your beliefs about what's going on are often incredibly bizarre, but at the time that you're doing it, you have no insight into the fact that this is not real. So there's a lot of overlap with psychotic experiences in that way, with hallucinations, delusions, and often poor insight. There is some evidence that both might be mediated by the chemical dopamine. That dreaming, not so much nightmares, which are often mediated by noradrenaline, but regular dreaming may be driven by dopamine, and that dopaminergic pathways in the brain are involved. And we know that dopamine plays some role in psychosis and in the treatment of psychosis. Patients who have had lesions in certain dopaminergic pathways in the brain report a cessation of dreaming. And so it does kind of build this case that there is this kind of common underlying chemical and possibly kind of pathway between the two. It's as I say, when you ask questions about sleep medicine, most questions will be prefaced by, we really don't know, but, and I think this is certainly one of those questions.
That's fascinating. And you say dreaming and nightmares are quite different in how they arise, or how we think they arise.
Yeah, we think so. And the reasoning behind this is that nightmares are improved by drugs that block the action of noradrenaline, not drugs that block the action of dopamine. And so we think that noradrenaline is involved. And normally when we're in REM sleep, which is when we have most, although not all of our dreams, there should be essentially no noradrenaline activity in the brain at all. And so the fact people have nightmares, if you block their noradrenaline, the nightmares often get better. And that indicates to us that noradrenaline is probably present during REM sleep when it shouldn't be there, and that this might be what's then driving the nightmares. And we know that, for example, in PTSD, that you get raised levels of noradrenaline in the cerebrospinal fluid, which indicates that there are probably higher levels in the brain. And this does seem to correlate with symptoms, and in particular with nightmares.
Do you think there is the fact that, I guess, these pathways exist and that these things happen, is there a function to dreams, to nightmares? That's maybe a big question, and I appreciate it won't be an answer, but what do you think?
So there's always been this big debate as to whether dreams are meaningful or not. And in the one camp are the people who've said, well, when you go into REM sleep, which is when you do most of your dreaming, you get these ascending waves from the reticular activating system, which stimulate the cortex, and then the cortex generates this imagery. And because this is all being generated in kind of the base of the brain, where you don't have any higher functions, the images that are being thrown out are completely random. And all that's happening, all that dreaming is when you wake up, your brain doesn't like having random images, so it assembles them into some kind of story. The opposing camp have said, well, no, actually, we think that dreams are meaningful. Firstly, you do dream outside of REM sleep, not as much or not as vividly, but it does happen. I think for me, one of the best lines of evidence was in experiments they did on cats, where they cut a particular area of the pons, and these cats were then not paralyzed during REM. And when they went into REM, they got up and they engaged in really purposeful behavior, appearing to hunt imaginary mice or playing with imaginary balls. And so they weren't just kind of doing random things. This was quite purposeful behavior. And so I think really now probably the weight of evidence is that dreams are meaningful, and that our brain is generating this imagery somewhat deliberately. And one of the theories is that it's our brain's way of training for stressful situations without us having to be in that situation. That it's a bit like, if you kind of use the IT term, it's the brain sandbox, that where it gets to try out different things without there being consequences. And so it's the brain's way of training. In terms of nightmares, we think that nightmares, everyone has occasional nightmares, and we think that occasional nightmares are functional, particularly for children, that, around the age when children are learning that there are things in the world that are dangerous, is also around the time when they have the highest rate of nightmares. And so nightmares might be the brain's way of teaching that child, you don't go, you don't wander away from your mother in a crowded street. You don't pick up a snake. So it's the brain's way of kind of, really kind of doing a fire drill for the brain, if you like.
Interesting. Hugh, this has been a whirlwind, and it's been amazing. I guess I wonder, as we draw to a close, is there a sort of a golden nugget of advice that you would give to people when it comes to insomnia and managing their sleep? Is there sort of a key or a couple of key principles that you think people should take away?
Yeah. So it's so difficult to pare it down to just one or two things, but I guess if a very basic bit of advice that I would give to anyone who has insomnia is set an alarm to wake up and get up at the same time every day, so that you anchor your body clock and you start to build up your sleep fuel. You build up that adenosine. You start to build it up at the same time every day. Don't nap in the day. Even unintentionally nodding off in the back of the bus, you're going to use up some of your sleep fuel. And then try going to bed later. As bizarre as that may seem, the later you go to bed, the more full your tank will be with that sleep fuel, and the better you'll sleep. And it'll also help you to kind of learn the difference between being tired and being sleepy. We use these terms very interchangeably in normal society, but actually they're very different things. And when you've got insomnia, you're tired a lot of the time, but not always sleepy. And just pushing your bedtime a bit later helps you to start to experience that sleepiness. And that can often be a really good first step to starting a journey to sleeping better.
Amazing. Thank you. And Hugh, if people want to sort of learn more about your work or what you do, is there anywhere that people can find you, or any sort of talks that you have coming up, anything that we should point people to?
I think there are a few YouTube videos up there from myself, but also from many other really good sleep professionals. There are plenty of good books out on the market as well. And what I would say is that there's also quite a lot of rubbish out there. So when you do go looking for information, really look up the credentials of the person who's providing that information. Make sure they're not selling anything. It's more likely to be a bit more reliable.
Thank you so much.
It's an absolute pleasure. Thank you for having me.